I had the opportunity to talk at the ESMO Asia this year to talk about the perioperative setting. What are the tools that we have to manage our patients with locally advanced disease, with muscle invasive bladder cancer, in which way we have the neoadjuvant chemotherapy based on cisplatin eligibility. So MVAC, Gemcitabine plus cisplatin are the current standard of care. We are debating in between how many cycles of chemotherapy based on cisplatin we should give before or after. According to the VESPER phase 3 trial, well, we should give for up to 4 cycles of gemcitabine plus cisplatin or 6 cycles of MVAC. I think we are not going beyond 3-4 cycles of gemcitabine, cisplatin, or MVAC in the daily practice, but the trial was designed in that way. So I think, well, we should debate in what we have in the clinical trials and what we do in the daily practice. By doing that, MVAC or gemcitabine cisplatin, we achieve a complete pathological response rate of around 36% by using GemCis or 42% by using MVAC. Probably GemCis is better tolerated than MVAC, and this is the debate. All patients are eligible to receive MVAC, maybe not, and we should discuss about that. What do we have in the adjuvant scenario? Well, if the patient have not received cisplatin as a neoadjuvant treatment and the patients after cystectomy, they are fit enough to receive cisplatin, a standard 3-4 cycles of gemcitabine plus cisplatin is what major guidelines are recommending. However, because of the data from the CheckMate 274 trial with Nivolumab, we have the recent approval of Nivolumab. FDA approved Nivolumab in all comers. EMA, the European Medicine Agency, approved Nivolumab only for PD-L1 positive patients with high risk of relapse. So what are the news that we have in this field? The news are that the Ambassador trial with Pembrolizumab phase 3 trial will be released shortly, hopefully at ESMO, at ASCO GU meeting in San Francisco in late January next year. So this is changing the scenario because up to now we have only one positive trial, CheckMate 274 with Nivolumab, and one negative trial, the IMvigor010 with atezolizumab. And this lack of consistency in the data of the novel immune checkpoint inhibitors as an adjuvant treatment were creating a little bit of doubts maybe in some of our colleagues in the community. And now the recent press release of the positivity of the phase 3 trial with pembrolizumab probably is going to bring some light to the field. So immunotherapy is coming to the field of perioperative setting. That's very good news for patients. And what we are really expecting shortly, and next year in 2024, we will see the first results of the phase 3 trial combining chemotherapy plus immunotherapy, and also the new potent, exciting, and I would say sexy antibody drug conjugate that we have, Enfortumab vedotin, with immunotherapy as neoadjuvant treatment in both patients eligible and also patients ineligible to receive cisplatin. This is the next frontier that we have, the next challenge that we will need to face. And unfortunately, we still don't have any biomarker to select the activity other than the use of Galsky criteria, the clinical Galsky criteria to identify patients to receive cisplatin or not.